and welcome to the ASCO Guidelines podcast, one of ASCO's podcasts delivering timely information to keep you up to date on the latest changes, challenges, and advances in oncology. You can find all the shows, including this one, at asco.org/podcasts. My name is Brittany Harvey, and today I'm interviewing Dr. Lisa Hicks from St. Michael's Hospital and University of Toronto and Dr. Joseph Mikhael from the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center, co-chairs on treatment of multiple myeloma, American Society of Clinical Oncology, Ontario Health, Cancer Care Ontario, Living Guideline. Thank you for being here today, Dr. Hicks and Dr. Mikhael.
Thanks so much.
Pleasure to be with you, Brittany. Thank you.
Before we discuss this guideline, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The disclosures of potential conflicts of interest for the guideline panel, including Dr. Hicks and Dr. Mikhael, who have joined us here today, are available online with the publication of the guideline in the Journal of Clinical Oncology, which is linked in the show notes. So then to dive into what we're here today to talk about, Dr. Mikhael, I'd like to start by recognizing that this guideline updates the 2019 ASCO CCO guideline on the treatment of multiple myeloma. So what prompted this update, and what is the scope of this updated guideline?
It's amazing when we think back in myeloma years, 2019 actually seems a very, very long time ago because really so much has changed in myeloma over these last 6 to 7 years. Indeed, there have been over 150 randomized controlled trials that we didn't have at the prior guideline that we reviewed for this. Myeloma is a disease that has really changed so dramatically over these last several years. Multiple new agents have been introduced. We now have CAR T-cell therapy, bispecific antibodies, and multiple other agents that were not available at the time. Furthermore, with this growing complexity, it's becoming more important than ever to be able to provide practical advice and guidelines to the oncology community, where most oncologists, they have less than 5% of their time dedicated to multiple myeloma. It's important to bring a clarity to them that allows them to care for their patients. And the scope of these guidelines, furthermore, really cover the whole spectrum of myeloma. They go further than our prior guideline, where now we've included smoldering multiple myeloma, along with frontline therapy and relapsed multiple myeloma. So we've really tried to provide the full spectrum to our colleagues in oncology to ensure that they have the tools they need to provide the best care possible for their patients.
That's a really terrific summary. And maybe one thing I'll just add is it's really unique to have this much literature. I can't think of another guideline that I've ever been involved with that has seen a field move so quickly and develop so many advancements in a period of just over 4 or 5 years.
Certainly, there's a large volume of evidence that you all had to review for this guideline update. I think, to your point, probably one of the greater volumes of literature for a guideline update that you both mentioned. Based on that, I'd like to review the key recommendations that are updated in this guideline. So, Dr. Hicks, that new patient population that Dr. Mikhael mentioned earlier, what are the key recommendations for patients with smoldering multiple myeloma?
So this is the first time that an ASCO guideline is addressing this branch of multiple myeloma care. It's an area where I think some guidance is needed. And smoldering myeloma is not an active cancer. And so one thing that I really want to highlight is that the panel felt very strongly that to recommend any therapy in this space, we needed a higher level of evidentiary certainty, of evidentiary confidence to make recommendations for active therapy. The panel really made 2 very important recommendations. First of all, the panel did not recommend treatment for low or intermediate risk smoldering myeloma. That's important. And then the area where I think for the first time we have recommended consideration of treatment is patients with high risk smoldering myeloma. And for patients with high risk smoldering myeloma, the panel recommended that it was appropriate to consider either treatment with daratumumab or careful observation.
And I think that move forward, as you've mentioned, Dr. Hicks, is particularly important because it is an area to some degree still of equipoise and many trials are going on in the area. But we do now have a strong phase 3 trial that supports the use of daratumumab monotherapy for 3 years when compared to close observation. But of course, that's not for everyone. I mean, one of the key themes of all of our recommendations are going to be now that more and more choices are available, but we have discussions with our patients to ensure that we match the right treatment with the preference of the patient. And I think that's particularly important here in smoldering myeloma.
multiple myeloma care and the multiple myeloma evidence is really so nuanced. And one of the nuances that readers will appreciate if they read the guideline is that how smoldering myeloma is risk stratified, it has been different across different trials. And that really adds to the complexity of this recommendation and is one of the reasons that the panel felt that it was appropriate to recommend either observation or treatment.
It's great to have these new recommendations for this unique patient population. And as you both mentioned, that individualized patient care is really important across this entire guideline. So then following those recommendations, Dr. Mikhael, what is recommended for initial therapy, autologous stem cell transplantation, post-transplant therapy, and measurement of response for patients with transplant-eligible multiple myeloma?
Well, that's an area that has really considerably also grown since the last guideline. Obviously, one would have to consult the guidelines to get every last detail, but in essence, we want to assess whether or not patients are transplant eligible or ineligible. And that assessment is not based on age or renal function alone, but indeed on a careful assessment of that patient. When that assessment is made and deemed that a patient is transplant eligible, our recommendation is that a patient typically would receive a quadruplet, that is to say, a monoclonal antibody directed against CD38, a proteasome inhibitor, an immunomodulatory drug, and dexamethasone to be given for approximately 4 to 6 cycles, followed by the stem cell transplant, followed by potentially another 2 cycles of consolidation, and then maintenance therapy. A couple of important caveats. One, we do have 2 different CD38 antibodies that can be used, either daratumumab or isatuximab. Although typically bortezomib is the preferred proteasome inhibitor, consideration can be given to carfilzomib by virtue of the potential toxicity from bortezomib. And then lastly, in the maintenance setting, we're typically recommending at least lenalidomide alone, but consideration can be given to dual maintenance therapy as the data is emerging to either add to that a daratumumab or carfilzomib. All the while using the IMWG criteria for response, the goal, of course, is to achieve the deepest response possible and to maintain that response until such time as patients would relapse. Finally, the length of maintenance therapy continues to be an area of equipoise and study in multiple myeloma. And so at minimum, patients would receive 2 to 3 years of maintenance therapy. And based on risk status and depth of response, it can be considered that patients would potentially come off maintenance therapy, of course, always with the caveat that toxicity would influence length of therapy as well.
Yes, as you mentioned, evaluating which patients are eligible is extremely important for considering what's recommended in the guideline for both transplant eligible and transplant ineligible patients. So then, Dr. Hicks, following those recommendations for transplant eligible multiple myeloma, what are the recommended treatments, goals of therapy, and measurement of response for patients with transplant ineligible multiple myeloma?
I really can't emphasize enough how important an individualized patient assessment is. When we're thinking about the range of patients that are included in this category of transplant ineligible patients, it's a huge range. You may have fairly fit patients in their late 70s all the way to patients in their 90s. And we really want to see that treatments are tailored both to the fitness of the patient, their individual circumstances, and their preferences. And it's a wonderful thing to have lots of options for patients in this circumstance. What the guidelines have recommended for most patients who are transplant ineligible but fit enough for a stronger therapy is quadruplet therapy. So actually therapy that's very similar to what's being recommended in the transplant eligible population, but for a longer period of time. And then for those patients who, for whatever reason, be it their fitness or their preference, are not appropriate for that quadruplet therapy, the recommendation is for triplet therapy with a combination of lenalidomide, bortezomib, dexamethasone, or very often, more often in most cases, an antibody-based approach with an anti-CD38 plus lenalidomide plus dexamethasone.
The only thing I would add to that, I think we have to also, as we do mention in our recommendations, be particularly cautious with the dosing of these medications, because even though we think of them as a single agent or a particular class, there can be quite a variation within the dosing regimen that can affect a patient's side effects and their quality of life. And so being very careful with dose modifications, in particular in the transplant ineligible patient, is an important part of the recommendation as well.
Yeah, this is a podcast, so no one can see me nodding vigorously. that dose modification is so important, particularly with those older and frailer patients, and with particular attention to trying to reduce dexamethasone doses and favoring weekly administration of bortezomib when that drug is used.
Absolutely. Considering the risks and benefits and patient preferences is really key to selecting therapy for these patients. So then, Dr. Mikhael, for the final overarching patient population addressed in this guideline, for patients with relapsed or refractory multiple myeloma, what treatment options are recommended?
This, of course, is, if you will, the biggest part of the guideline because there's been so much done in the relapse setting. And I think we start the guideline by saying a decision has to be made as to when to institute therapy, that there may be some patients with slow biochemical relapse that may be monitored for a period of time. But when the decision is made to initiate treatment, instead of a simple algorithm, the guideline emphasizes the fact that there are multiple choices that can be given to a patient that are going to match what comorbidities the patient has, what they've been treated with before, and of course, what their preferences are. I think we highlight two particular areas that now that CAR T-cell therapy is available as early as first relapse, it should be a consideration by virtue of the fact that it has resulted in such deep and durable responses. But that triplets should also be considered in that earlier relapse setting because we do have multiple classes of agents that can be used. We know that in later relapse, options exist, including bispecific antibodies, for which we have 4 different choices, and that in general, patients will ultimately receive either a triplet or CAR T-cell therapy in earlier relapse, but there are some patients who may be eligible only for a doublet by virtue of their comorbidities and of their prior therapies. Lastly, it really does emphasize the point, as we've mentioned a few times in this podcast, and I'm so glad it keeps coming up, is that, as I often say, we don't treat myeloma, we treat people. And engaging the patient in that conversation to ensure that the right treatment gets matched to the right patient is particularly important, because with all the new classes that we have with antibody drug conjugates, with XPO1 inhibitors, the traditional 3 classes of proteasome inhibitors, immunomodulatory drugs, monoclonal antibodies, along with, as we've already mentioned, CAR T and bispecific antibodies, it really is an incredible laundry list of choice. And making that choice specific to the patient becomes absolutely critical. I should also lastly note that there are patients who may defer their initial transplant. There may be patients who may be eligible for a second transplant. So autologous stem cell transplant, although primarily used in the frontline setting, may still be a consideration for a smaller subset of patients in the relapse setting.
I think maybe one thing that I would add is an overarching principle, which is actually similar to a principle in the first guideline, and that is that in the relapsed and refractory setting, there are many different treatment options. And in fact, the number of treatment options feels like it's evolving every day. But an overarching principle for clinicians to consider is to try and choose combinations of drugs that the patient has either not been exposed to in the past, or certainly that they are not refractory to. We really want to be pulling new options out of the toolbox as much as we can.
Very often we do see where someone may be on a triplet and they're progressing on it and someone just changes out one drug. We've suggested not to take that approach, but to take the approach of completely introducing a new therapy when someone is progressing on their current therapy. I think that point is particularly important, and the consensus panel was very clear.
Understood. That's very helpful when thinking about what options to offer to patients in the relapsed and refractory setting. And as you mentioned earlier, the figures in this guideline provide an outline of options, and then the tables really go into some of the details and outcomes of the trials, and those are very helpful for clinicians to refer to. So then, Dr. Hicks, we've talked a little bit about some of the nuances of the guideline, but what should clinicians know as they implement these new and updated recommendations?
I think they should feel comfortable that these are trustworthy guidelines. So these are evidence-based guidelines that have been rigorously developed after a very thorough evidence review and put together by a panel of experts who were extremely thoughtful in their review of the evidence. And so all of this contributes to the trustworthiness of the guidance. And then I would also encourage people to take a deep look at the guidelines because of the importance of nuance that's addressed in them. And then to also explore some of the tools that ASCO is developing that helps with implementation, including the flowcharts that are contained within the guidelines and some additional tools that are available online.
Absolutely. The tools and resources for this guideline are available online with the publication, and we'll provide links to that in the show notes of the episode. So then following that, Dr. Mikhael, how does this guideline update affect patients with multiple myeloma?
As we sort of intimated earlier, I like to say I don't treat myeloma, I treat people. I think we should always be patient-centric and patient-focused. And I think in the discussion, we always were. We always wanted to ensure that multiple factors go into a decision-making process. We're not just looking at the biology of the disease, we're looking at patient factors. Those patient factors include their frailty, as we commented in frailty assessment, their preferences, their comorbidities. And I think in a day where we have so many choices, we emphasize in the guideline the importance of that conversation with the patient, that, if you will, shared decision-making model where options are laid out and based on the patient factors and the treatment factors, they can then be meshed together in the best way so that patients can make the right choice. And of course, in conjunction with the guidelines, we have patient-friendly summaries of them, and we involved, of course, patients in the development of these guidelines. And I think that is one of the greatest strengths of the ASCO guidelines, is that there is a patient with us at the table who is giving their perspective on the guideline as we go forward. So I'm very thankful that we've created a product that is, if you will, not only for the providers, the practitioners that are prescribing these agents and that are directly giving the care, but indeed for the very patients who, of course, have the most at stake here.
Yeah, Joe, I'm so glad you called out the participation of patient partners in the guideline. It's such an important part, and they were really, the patient partner was such an important part of this panel in helping us understand the patient perspective as we develop this guidance.
Definitely. It's a hugely important role for the panel and for all of the panel, including the patient partners and the experts in the disease, to review the evidence and come up with comprehensive recommendations. And yes, as you mentioned, the individualized treatment and the shared decision-making is really paramount to this guideline. Finally, Dr. Hicks, you alluded to earlier the vast number of treatment options that's really exploding in multiple myeloma. And so this guideline is becoming a living guideline, continuously updated by ASCO. So what are the outstanding questions regarding this topic, and what evidence is the panel looking forward to for future updates?
I'm really excited about this. This is one of the first guidelines that will be a living guideline for ASCO, and it is such a good fit. You've heard Joe and I say a few times how quickly this field is moving, how complex the field is. I think everyone on the panel knew that no matter how quickly we did it and how deeply we reviewed the evidence, it was inevitable that more evidence would be generated as we were putting out the guideline. In a field like that, it's really important that we find a way to provide evidence-based guideline quickly to the community. You know, waiting another 5 years, letting another 150 trials accrue before we do another guideline is not what the community needs. And so ASCO has really risen to this challenge and is committed to living guidelines. And so a living guideline is a guideline that commits to reviewing the evolving evidence on an ongoing basis, watching for practice-changing trials, and having a standing panel that will review evidence and update recommendations on a regularly scheduled basis. So that's what a living guideline is, and that's what this guideline is becoming. That's just the first thing in terms of what a living guideline is. And then what are we watching? Well, honestly, what aren't we watching? There is so much happening in multiple myeloma. We knew as we put the guideline out that there were trials in process, some trials that had been released at conferences but not yet published. We'll be waiting for those, and if they're practice changing, they'll be addressed in upcoming updates. There's new evidence just recently presented around combined anti-CD38 and bispecific antibodies. I don't know yet whether that will be addressed, but I wouldn't be surprised if it was. There are so many things coming down the pipeline, and it's just wonderful that there's going to be a way to try and address them in a robust fashion.
Yeah, I agree with you, Lisa. I can't think of another disease that would be more relevant for a living guideline. I mean, we had difficulty because new data kept coming in as we were making recommendations. And so at some point, we had to draw a line and say, this is where we'll stop and produce this guideline and have it ongoing. And I really look forward to seeing the updates, because we know, as you mentioned, that there's so many things that are on the verge of approval and on verge of changing the way we manage this terrible disease. And before I close, I would love to remind all of our listeners that, as we commented from the start, patient engagement is critical at ASCO and in our guidelines process. Unfortunately, we lost a very dear patient during the guidelines process, and that is Jack Aiello. And Jack Aiello had been a patient and a patient advocate for many, many years in the myeloma community. And indeed, we've actually dedicated these guidelines to his honor. And so I thought it would be valuable for us to mention that today. And we miss you, Jack, but we're very grateful that we've been able to dedicate this excellent body of work to your memory.
Absolutely. This guideline and your dedication to him is an honor to his memory, and we really recognize him in thinking about this guideline. We'll look forward to those future trial results that you mentioned, Dr. Hicks, to update this guideline and continue to provide options for patients with multiple myeloma and improve upon those options and shared decision-making with patients. So I want to thank you both for all of your work to develop this guideline and for your time today, Dr. Hicks and Dr. Mikhael.
You're so welcome. Thanks for featuring this guideline.
Thank you so much, Brittany. It's been a privilege.
Finally, thank you to all of our listeners for tuning in to the ASCO Guidelines podcast. To read the full guideline, go to www.asco.org/hematologic-malignancies-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, which is available in the Apple App Store or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.